to Dr. Chuks.
Lovely, lovely. Well, thank you guys for coming out today. It's an honor. Thank you, Katie, for having me. I think it's great that you have a society such as this. I think it's good. I wasn't part of anything like that when I was going through med school, so I think that's fantastic. Really, really brilliant. This is a massively under-discussed topic, in my opinion, and I don't know how much gets talked about at university and med school about it now, but I know when I was at med school, we got, some weeks on psychiatry, let alone eating disorders, that was even less. And, that was apparently above average compared to some med schools around the country. So we don't get too much, but as you can imagine, the course is so rigorous. There's a lot to learn. And it is quite hard when you think about timings, but I definitely think, considering the numbers you've explained earlier, I definitely think that med schools, we can maybe push for there being some more knowledge on this topic of eating disorders. I'm conscious of the time, so we'll try and stick within the frame of allocated, and hopefully should be some time afterwards for questions. And so eating disorder, so continue. Okay, eating disorders. Let me just, how do I slide? Hold on a sec. Okay, so yeah, just a warning. Obviously some of this content might be triggering, and I thought I'd just say that off the bat, because obviously this is can be quite sensitive. So I just thought I'd give that as a heads up. So plan of action. Firstly, I tell you a little bit about me and my background. Then we'll go talking about eating disorders, and then I'll talk about like the inpatient care and my job, and then we'll talk a bit about the medical management. And then, like I said, at the end there'll be questions. Can everyone see my screen okay? Is that all right? Right, brilliant, fantastic. So firstly, a bit about me. So I was born in London, born and brought up in London, of Nigerian heritage. My parents moved over here in the 90s. Went to University of Manchester. So there's that proximity with Liverpool. Although interestingly, I was there for 5 years in total, but I never actually journeyed out there apart from to watch my football team play. So yeah, doctor in eating disorders, been in this specialty for coming up to 3 years now. I'm a Christian. I take my faith quite seriously, and it's a key part of how I kind of view the world, view life. I play a few instruments, so I love a variety of music, and like I said, I'm a Liverpool fan, so I'm still reeling from yesterday's result. But we won't talk too much about that, just in case there are any Everton fans or Manchester United fans listening. I'll try not to mention any more about that. Oh, sorry. Okay, right. So, the reality. So this is basically this last year and a half has been a disaster, basically, when it comes to the world of eating disorders. And there's actually been, our hospital in particular, we've had a huge referrals list, absolutely huge referrals list, which has just worsened. I mean, we've always had it, it's always been big, but it's just kind of got really, really bad over this coronavirus pandemic. And there's all sorts of reasons for that. But there's been all sorts of media, in all sorts of different newspapers across the last year and a half. And, from children, you're talking about adults, anorexia, bulimia, it's kind of, and all the others. You talk about binge eating disorder, which we'll talk about, but across the spectrum, there has been an increase. So the probably the most common one, which people don't really talk about, is binge eating disorder. It does kind of get hidden at the back there. People, when you think of general public, the people I talk to who aren't in this field, when you talk about eating disorders, they think anorexia, they think bulimia. But actually, binge eating disorders, about 22% of those that have eating disorders have binge eating disorder. And this is categorized by kind of emotionality in terms of food, and those, what they say, typically twice a week for about 6 months, binge eating episodes, more than you usually would. And there's some other criteria which we use to categorize someone who has binge eating disorder. The ICD-10 code for all you ICD-10 enthusiasts out there is F50.81. Then there's avoidant restrictive food intake disorder, also known as ARFID. Again, we see it here, but we not to the same extent as some other eating disorders. It's closely linked to ASD. Primarily, there is often not that same extent of concern about body shape, body weight, but it's basically a restriction of certain foods, and there's a very sensory element to ARFID. And then there's others. There's EDNOS, eating disorder not otherwise specified. This is, if you like, the others that sometimes they don't fall in line with a particular diagnosis. So we kind of give it that. But as in psychiatry, diagnoses can evolve, and then eventually EDNOS can be categorized as a different something else. But EDNOS is often given to patients, and I think approximately 40% of patients are categorized as having EDNOS. So this isn't today's focus, but I just wanted to say it off the bat because, it's not any less important. These are very, very important and very prevalent, but we're just not going to focus on those today. We're going to focus on the ones that we typically see in hospital here. So that's firstly bulimia nervosa. So this is the obsession with eating and a desire for food, which leads to episodes of eating large amounts of food in a short period of time. So it can come with those episodes of eating or consuming more calories. And then efforts made to reduce the effect through purging, can be through purging, can be through calorie restriction, appetite suppressants, diuretics, a variety of ways. And the fear of becoming fat leading to desire to reach lower than ideal body weight. So I've taken this word for word from the ICD-10, how they actually categorize bulimia nervosa, so that intense fear of weight gain. So they don't necessarily reach a lower body weight, but there's definitely a desire to get there. Bulimia nervosa, I put the trainers on there because people typically think bulimia, purging, they think vomiting. Well, purging isn't necessarily vomiting. Just wanted to reiterate that purging is when you're trying to counteract the calorie intake, if that makes sense. So typically it's vomiting, but it can also be, for example, exercise. So I put those trainers there just to make that clear. 19% of eating disorder sufferers have bulimia. 25% of those are male, which was higher than I actually thought it would be, which just shows you the extent too. And bulimia is a notoriously difficult one to capture, actually. It's very, very secretive. So these numbers are very, very much conservative. Approximately 8% of women are estimated to have this at some point in their life. And we see the effects of dehydration, electrolyte abnormalities, because there's that. And not only is there the purging, which is ultimately getting rid of fluid, getting rid of the acid in the stomach. So you're not getting you're getting rid of fluid firstly, and then the acid-base balance gets thrown off, which you get deranged electrolytes. You're talking about hypokalemia. Primarily is a big concern, but also the laxative use, which is again another form of purging, which can also cause dehydration. And again, for those ICD-10 coding enthusiasts, it's F50.2. Okay. The more you're in this field, the more you realize, and a few of my consultants have said that ICD-10 coding, as good as it is, there's so many nuances and every patient's so different that we try not to bog ourselves down too much with the coding, although it's important.
I'm not hearing.
Sorry, sorry, that was me.
Is that, oh, sorry. Oh, is that all right? Can you hear me now?
Yeah, it's back on.
Yes.
So, yeah, so some people end up with bulimia nervosa who had anorexia and vice versa. So diagnoses in psychiatry in particular can often emerge over time. You know, if someone has one episode of a depression, you might not necessarily know whether they have just a sole depression or whether that is as part of something else. So again, if diagnoses can emerge. Bulimia is you have what's called diabulimia, which is closely linked to that. People tend to put it under the same coding as F50.2. So it involves those who have diabetes. And as we know, when we release, when people have insulin, that have diabetes have insulin difficulties, or they end up with having issues with regulation of sugar, blood glucose. And it's really, really important to understand this, because they have issues with taking their insulin. Often this is the insulin dependent diabetics. If you don't take your insulin, it could be fatal. But they don't like taking the insulin, because when you take the insulin, insulin means that the energy gets used up and processed, and the energy can be stored in our fat cells. So what you end up getting is patients who suffer with diabulimia avoid taking their insulin, so that energy can't be stored, hence they avoid the weight gain. But unfortunately, if they don't take the insulin, it can end up being fatal. So we've had a few patients like this, and it's trying to work with them in a collaborative way to try and identify the root cause of where these cognitions kind of stem from. Okay. Then there's anorexia nervosa, probably the most common one, but interestingly less common than bulimia and binge eating disorder. Avoidance of high calorie foods, at least one, of self-induced vomiting or purging, excessive exercise, appetite suppressants, diuretics, laxatives. We typically see this. Disordered image. These are altogether, these are what we use to calculate. That's why hence the calculator, calculate anorexia nervosa as a diagnosis. Distorted body image, endocrine dysfunction, females with amenorrhea, males with loss of libido, and we have prepubertal onset, so puberty may be delayed. In girls, we talk about underdeveloped breasts that haven't developed by the age of 13, no menstrual periods by the age of 16, and boys who haven't seen a growth in their penis by the age of 14. This is delayed puberty. And then you have the actual body weight, which is 15% less than what we would expect for that person's sex and height. And body mass index, we often use that as 17.5 or less, although there are calls for increasing it to 18.5. But as it stands, it's 17.5 or less. And all of these together are used in order to give a diagnosis of anorexia nervosa. 8%, like I said, of eating disorder sufferers have anorexia. The average age of onset is very, very early. I've heard of a case of someone being diagnosed as early as 7. It's the highest mortality of psychiatric illness, which is why we probably see more of it, because I work in purely, just in case I didn't make it clear, I work purely inpatient adult eating disorder. So we're seeing a lot of anorexia because they have a higher imminent likelihood of death, and we make that very clear. So in a lot of ways, I do feel like, along with the team here, that we're working in A&E to some extent. we've seen some very unfortunate things, with our patients who have gone into the community, and this pandemic, like I mentioned earlier, has just made things a whole lot worse. So, the difficulty is we have situations where the waiting list is so long, and there's only so many beds, and the general medical hospitals really aren't conducive to properly managing someone who has a chronic illness such as anorexia nervosa. And sometimes, the hospitals try their best, but I think it's not really a space that they're used to dealing with that. And we'll get to the reasons why it's so important that patients sometimes come into a specialist eating disorder unit. So anorexia affects all body systems. And the reason why I put the chili there is just to highlight how it can affect all the different body systems. For example, the gastrointestinal tract, which is the obvious one, and the musculoskeletal system. So we know that the muscles store glycogen, and then you get glycogenolysis, you get breakdown of the glycogen when your body's malnourished, and you get muscle wastage. You just in general get malfunctioning of the body systems, and the lower esophageal sphincter, which we have at the base of our food tube, the esophagus starts to not work as well, and it's flabby. It's not as, the tone isn't there in the way it should be. Hence why people are more likely to suffer reflux and be more sensitive to spicy foods. So we typically get that, and the patients are struggling with reflux and things. We can prescribe medications for that. There are all sorts of medications that we can prescribe throughout the process of someone's recovery here in hospital. But I decided not to talk about that today because there's so many, and we'll just kind of get into a pharmacology lesson, which is probably not what you guys at 7:30, kind of want to do. So I thought I'd stay clear of that. ICD-10 coding. F50 is typical anorexia nervosa and atypical F50.1. The main difference being that atypical is someone who has all but the weight being kind of that 17.5 BMI or 15% less kind of body weight. It's not the best terminology, to be honest, typical, atypical, but it's what they currently use because everyone's presentation is different. So the concept of typical, atypical is not ideal, but that's what we use in psychiatry. All right, inpatient care. So MDT is really, really, really important for inpatient care. So I work with a consultant who kind of oversees everything, and then there's dietitian, we have occupational therapists, we have psychologists, psychotherapists, art therapists, people who work with the family team, social workers. And I think eating disorders is probably, I can't think of many specialties that the collaboration is so critical. Social support workers, the HCAs, the healthcare assistants that work on the shop floor with the patients, making sure that they're following the plan or their treatment plan. Everyone's really involved, and that's a really, really key about this space, which is so great. And I think across the whole of psychiatry is very much an MDT process, much like in other specialties, but obviously I'm talking from my perspective. First episode and rapid early intervention. So this is FREED, what we call FREED. This is typically when someone's had it for less than 3 years, between the ages of 16 and 25. Ideally, if we pick up people or patients early, this is the gold standard, really. This is where research says that we're most likely to get on top of it, and they won't end up in that 20% who are chronically unwell, and they'll be more likely to recover. And we have severe and enduring eating disorders. Severe and enduring eating disorders are, it's a controversial label in itself, but it's what is typically used. It's for those who have had an eating disorder for over 7 years. Again, the criteria changes based on who you talk to. Some people do it based on the number of admissions. Some people do it based on the number of years with the illness. But more commonly, it's above 7 years of having it. And for someone like this, we're really focused on improving the quality of life, stabilizing them physically, mentally, making sure they feel more psychologically safe. But someone like this, who comes into our hospital acutely unwell, we would be unlikely to look to get them to full weight restoration, because we're talking about pre-morbid weight, because it's just a different strategy basically, and you have to think about who you're dealing with. You have to tailor it. So yeah, like I said, we mainly deal with anorexia nervosa. The inpatient admissions are typically months, not weeks, because there's a sweet spot in terms of physical recovery, and it takes time mentally, because you have to have a lot of, patients have sessions with psychology and all the rest of it. So it's definitely, inpatient care is very, very difficult. And I always champion my patients. I tell them, I massively respect you guys. You've left home, you've taken a bold step, to often very, very far, to come and get treatment, and typically months away. And as you can imagine, COVID period was an absolute nightmare, because people to go home and to, was challenging. To come in, visitors was challenging. So yeah, typically months. So inpatient care is a last resort. Ideally, community is what we want. But this is where they can get back on track as in inpatient care, and then they can continue the work often in the community. Unfortunately, it does depend on where in the community the services are. Some are slightly better than others. Some have more funding than others. It's difficult. It is really, really challenging. But this is the situation we find ourselves in. Last resort. So the job, what do I deal with just quickly? So referrals, I'm involved in the referral process of patients coming into the hospital. I clerk in patients, so I take a full history, including the history from the families, or support network. It's very, very important. Firstly, because patients, unfortunately, the illness hides things, so they probably won't always be honest. And secondly, because there's some things that the patient just won't remember. We talk about birthing histories and all the rest of it. So it's quite nice to have a collateral history. Physical examination of body systems, bloods, and ECGs. So these are the very medical things that happen on admission. This is really, really important. ECGs, bloods, these are very basic. And this is where eating disorders is different to other psychiatric specialties, because there's actually quite a lot of focus on making sure that these are absolutely right. Now, don't get me wrong, bloods and ECGs are done in every specialty, every subspecialty of psychiatry. However, in particular, eating disorders is done probably much more so, because they come in so acutely, physically unwell. And yeah, we do those daily. But I'll go into the acute management of it later. And this is important because not often, but sometimes we do send them to general medical hospital. They've just come in so unwell. And sometimes we're amazed by how unwell someone has come in. Typically if they come in very unwell, it's to transfer from general hospital, but sometimes it's straight in, and we have to make a clinical judgment of how we go about that. So yeah, sometimes we send them in. So that would be my job, and I would liaise with my consultant, of course. And GP community, we're liaising with them. This is whilst they're here. Also on discharge, that's my job. Education sessions, this is kind of voluntary, I guess, but I guess I kind of enjoy talking to my patients just about and alleviating some of their concerns. So every week I take it in turns with the dietitian, and we educate the patients on all the different body systems and questions they may have about their skin, about their hair, why am I breaking out, all sorts of different concerns, bowel concerns, and why am I getting palpitations? It could be anything, but the dietitian does nutritional advice and all the rest, and dietetic tips, and just education, which is really good. And I guess it's one of the duties of a doctor. So they teach us in medical school, duties of a doctor is part of it to teach and educate. It doesn't mean you know everything, because every day I'm learning, of course, but everyone can teach where they're at. And actually everyone in healthcare really should kind of generate the habit of teaching. The little that you know, or the lot that you know, just keep teaching, keep learning. Nasogastric tube insertion, we have to do this from time to time. Using the Mental Health Act from time to time, detaining a patient if the situation requires it and they're at risk to themselves. And report writing, quite a lot of report writing. I don't particularly enjoy it very much, but it's important because communication is key in psychiatry, along with the whole of medicine. Reflective practice, we engage in that. And prescribing, there's lots of prescribing. There's probably a few other things, I haven't put in there, but those in general, that's the job. So there is a lot. There's enough to keep me busy, that's for sure. Okay, so medical management. We use the Royal College of Psychiatry Marzipan guidelines. It's kind of ironic, really, that it's called Marzipan and we're talking about. But anyway, Marzipan guidelines, management of really sick patients with anorexia nervosa. Now, we kind of use this for patients with bulimia nervosa as well, but it's kind of technically it's a misnomer. However, this is really kind of fundamentally it's for anorexia nervosa, and it's really, really clear. And I know BMI is very controversial and people don't like talking about it so much. And there are definitely talks of adjusting the way it's used. However, there are criteria that the Marzipan guidelines stipulates. It says very high risk. And by the way, we're talking about high risk of death. We're not talking about high risk of hospitalization. We're talking about death here. So this typically coincides with those physical symptoms we talked about earlier. Amenorrhea, no periods. You talk about loss of libido and other things which kind of fall in line with, or bone problems, osteoporosis, some of the things that you typically get when someone's very ill and unwell and malnourished for a very long period of time. So we categorize low risk, 15 to 17.5 BMI, medium, 13 to 15, and high, less than 13. Of course, based on the patient and based on their individual needs and goals, we would change where we set the target for that admission, and the discharge would be very different. So it's very challenging for patients who are here, because the nature of the illness can be quite comparative, and you have someone who's on a completely different plan to you. The discharge plan might be completely different, and it can be very hard for them to stay focused on themselves. But we just encourage them to do that. Okay, so we start off with when they come in, someone's very, very, very unwell, comes in the front door. We start off with our supplements. So we give them thiamine, that's 100 milligrams twice a day, phosphate, potassium, and multivitamins. These are really to drop. We give it to them off the bat, and I'll explain why it drops later on. We also do bloods, full blood count, urea and electrolytes, liver function tests, phosphate, magnesium, B12 and folate. This is really important because full blood count, typically patients come in with neutropenia, they have bone marrow suppression. So they at increased risk of infection. Hemoglobin is typically low with anemia. We have urea and electrolytes abnormalities. Like we said, that's typical with bulimia nervosa, and they're coming in with often very low potassiums, and we have to give, like I said at the start, 7 days worth of potassium, Sandoz, which is the common one, but there are others. Now, 7 days is just 7 days to begin with. It might increase beyond that. Everyone's an individual, and we tailor it based on the patient. B12 folate, B12 can be sky high in someone with eating disorders because the B12, as we know, is stored in the liver, and it's when the liver goes under, the liver stores glycogen, and so the body is trying to source this energy from somewhere. So you get the breakdown of glycogen. So the liver is almost overworking, and then you get this spillage of B12 around. So you end up getting very high levels. Thyroid function, the body's going into set power saver mode. So the thyroid becomes underactive, very, tries to slow the processes down, which is again one of the problems why our patients suffer with things like constipation, things like, just in general, their functions can be, bodily functions can slow down. Their skin gets very dry because the body's not focusing on that. Hair starts to fall out, unfortunately. Again, the body is not prioritizing that. It's prioritizing keeping this individual alive. And so we do all these tests to begin with, and then an ECG. ECG, typically we would see for someone who's very unwell with ECG changes, you'll get prolonged QT, which is very, very serious, and we can't have someone in that state for very long. Typically, we would monitor it very closely. Sometimes we have to send them into general medical hospital for cardiac monitoring. But really, the therapy is nutrition. This is why it's so important. The therapy is nutrition. And sometimes in general medical hospitals, there are difficulties with enforcing nutrition. And patient has close medical monitoring for 1 to 2 weeks while refeeding risks remain high. After then, we still monitor them, but it's less intense, if that makes sense. Okay, so dietetic review. This is the refeeding. The process of refeeding, the dietitian is linchpin. So important. They come up with a protocol which is right for the patient. Typically it's 10 to 20 calories per kilogram per day. Now this varies. Sometimes if someone's very malnourished and based on what they were eating prior to coming in, we would have to make that even less than that. What we don't want is we don't want them to enter into refeeding syndrome, which we will talk about next. Special considerations have to be taken into consideration for those with vegetarian or vegan or particular dietary requirements. For example, vegans in particular have very low phosphate because they're, phosphate which you can find in things like dairy and, kind of milk-based products. Being vegetarian, I tell my patients, being vegetarian, being vegan, these things aren't a problem. However, it's vital that people are aware of the extra steps that they need to take to make sure that they have a balanced diet. So everyone needs to do their homework to make sure that they're intaking the appropriate foods and making sure they're not deficient in any micronutrients. 45% of patients with anorexia were found to be deficient in one micronutrient. So it's vitally important that the diet remains balanced. But anyway, as part of the refeeding syndrome is when electrolytes kind of go everywhere. And why do they go everywhere? Because when the body's depleted, as you can see there, starvation, malnutrition, then the body breaks down the glycogenolysis, breaks it down and produces, it kind of breaks down protein as well. It gets depleted of its fats, vitamins, electrolytes. Anyway, through the process of refeeding, you get the insulin all of a sudden that has not been used to all this nutrition. All of a sudden the insulin gets released and you get this short and sharp intake of potassium, magnesium, phosphate into the cells, which reduces the amounts in the serum. Now, unfortunately, this can, as a side effect, can mean that the potassium, the sodium channels, the sodium channels on the membranes can start to overwork and push out the sodium. So you end up getting a lot of that in the extracellular fluid. So the intracellular fluid is extracellular is increased, basically, so increases the extracellular volume. So you end up getting things like peripheral edema, which is a massive struggle for many of our patients. Unfortunately, the process of refeeding is challenging, really challenging. The body goes through difficult phases. For example, sleep is a problem. You talk about bowels and bloating, and again, things like peripheral edema. There's all sorts of different things which are very challenging through the process of refeeding. Now, how do we avoid this refeeding syndrome problem? We avoid the refeeding syndrome. And by the way, refeeding syndrome can be very serious. You can get fatal cardiac problems. You can get the liver compromise, and it can be quite systemic, the problems. So how we avoid this is, like I mentioned earlier, we take it a very slow approach, steady approach, but we need to make sure that we don't go too slow to create an underfeeding syndrome. So we have to get the balance right. And the process is scientific. It's very mathematical. And this is why if you have a dietitian on an eating disorders ward, they can often be the linchpin, especially when it comes to these preliminary stages in the ward. So continuing with our management. So far we've done bloods, we've done ECGs, we've prescribed all our vitamins. We do these things daily until an appropriate energy intake is reached. And the blood tests are eventually reduced to alternate days. Then we do them twice a week. And then we do them like weekly, again, fortnightly. And then, we just take it from there based on the individual. And hospitals do it slightly differently, but it stems from the marzipan guidelines, which I mentioned earlier from the Royal College of Psychiatrists. You can, yes, you can take the bloods at the same time as doing urine samples. Urine sample, you can see things like ketones, urine-specific gravity. These can reveal quite a lot. You talk about ketones, ketosis. You can often get that when there's patients been over-exercising, or when someone's been starved themselves, or when there's been purging. You can get changes in those numbers. So there are all different ways in which you can identify the behaviors an individual is engaging in. And blood glucose monitoring. This is really important. Hypoglycemia is deadly. Hyperglycemia, I remember talking to a diabetic consultant, and he said that he's more concerned with hypoglycemia than hyper. Hyper, you have more time to do something about. Hypo it could kill you. So what we have is a situation where the insulin hasn't been released in the same or has almost like been, it goes under dysfunction when there's malnutrition. And so upon renutrition, the insulin starts firing out quite a lot of, the pancreas starts firing out a lot of insulin. And then what you end up getting is you get tendency for the blood sugar to drop in the middle of night, drop post meals as well, which is why it's so important to regularly monitor blood glucose through the process of refeeding. Then we do physical examination. We examine all the body systems. Like I said earlier, there's lots of things to find. You can get, you can examine someone's abdomen, depending on how unwell they are. You're talking about describing what you see, and everyone's an individual, but things like seeing the scaphoid abdomen, or seeing signs of malnutrition, dry skin. Again, this is there's a lot to examine on admission. Muscle power is reduced, and we can test that with a sit-up, squat, stand test, and I'll explain that in a bit. Or a hand grip strength test, which actually some places actually prefer to do hand grip strength test, and then you can see the strength improve throughout the admission. But these two scores are typically very low in someone who's come in and is very, very unwell, acutely unwell. Now, this is a safety issue. And again, everyone's an individual, so we will do it on a case-by-case basis, but typically it would be restrictive leave until it's been medically given the go-ahead. Full bed rest if medically unstable. Supervised toilet, bathroom use with limited physical activity. We're talking about lift, not stair use. A patient's, I said earlier, it can affect all the body systems. It can also affect the cardiovascular system. When they stand up, typically when we stand up as humans, 800 mils approximately of our blood pools to our lower limbs, and our baroreceptors in our carotids and our artery and our aorta kick in, which then pushes that blood pressure up. Unfortunately, you just don't get that. You just don't get that into the same extent with anorexia, because there's malfunction, there's malnutrition. And so we are very careful with the amount of physical activity we allow our patients to engage in. So lift use, not stairs, and full bed rest if the patient is very unwell. But this, full bed rest is really in extreme cases. So this is the sit-up stand squat, squat stand test. So the first is the sit-up test. So the patient will lie down on the floor, flat, and they'll try and raise themselves up to about 90 degrees. And you give them a score based on how able they are to do that. So without difficulty is 3. A little bit of difficulty, we give them a 2. If they're just unable to do it without their hands, we give it to 1. If they're unable to do it, 0. And this is the same thing with the squat stand. They just squat without using their hands. And again, the scores are the same. So this acts as a nice indicator of muscle wastage and how much power has been lost. So accurate assessment of the patient's nutritional status and eating behaviors. So we weigh them twice weekly. Some places do it once a week. It just depends. All we have to do is make sure that we're tracking this weight, which can again be very difficult for our patients. It's not something they enjoy. It feels like it can be quite shaming, because the patient has to wear a hospital gown while they're being weighed. Height, at the beginning of admission, we do this. We have known people to actually have growth spurts during their admission. So, it's nice to re-height them if necessary. We have to watch out with this one, that is someone who's used to doing it heights them, because patients can typically bend down or slightly bend their knees, so they come out as a lower height, which would push their BMI up. So it would give a falsely high reading for the BMI. So we make sure that we height them properly. Bowel chart, this is really important. Sometimes we're forced to prescribe things like laxatives. We don't use stimulant laxatives. We use osmotic laxatives like Movicol, because difficulties, like I mentioned earlier, with going to the toilet and constipation. Again, there's slowing of the bowel processes. The body doesn't put a focus there, it puts it into the other areas. Intake, we monitored their intake very closely. This could be good intake and it could be bad intake. It could be the intake, or for their meals that we monitor them, or let's say bad intake, and where we talk about falsifying their weight, weight with water loading and other things such as that. And so we make sure that bathroom doors are locked and supervised, like I said earlier. And we make sure that they're closely monitored and supported, most importantly, in the dining room, because it can be very challenging when they're faced with meals that they're not used to. Like I mentioned earlier, spicy foods. Sometimes we have patients who aren't used to certain foods, more blander foods maybe, and they come in and then there's more variety in hospital. So we monitor intake. Support during challenging times, like I mentioned, inappropriate fluid intake, like I've mentioned as well, and we limit contraband. We make it very clear to our the family support network of our patients to please, there are certain things which contraband, please do not bring it in. It's not aiding your loved one's recovery. Okay, so we use Marzi Muse. We use time runs away. We use the Marzi Muse, which is an adapted, it's an amended early warning signs system. So the early warning, typically what we use is, as you can see the numbers there, systolic blood pressure, respiratory rate 12 to 20, pulse rate 51 to 90, temperature sweet spot 36 to 38. So on the left, the news is typically what we would see in someone who is not unwell with anorexia or you know, severe malnutrition. And then on the right, as you can see, there's Marzi Muse. So the numbers are changed slightly. The reason why this is so beneficial is that Marzi Muse actually captures our patients more accurately where they are. So a lot of patients flag, for example, if a patient under my care has a systolic blood pressure of 90, 95, and that's normal for them, they would not flag with the Marzi Muse as it being, whereas if you can, as you can see in the news chart, it would flag as being, uh-oh, what's happening? Why is their blood pressure so low? So these are all the bodily dysfunction which happens through malnutrition, and we're trying to capture that in the Marzi Muse. So actually someone might be that way, but they will score according to where they are nutritionally. So we use Marzi Muse here in the ward, not the news chart. ICD-11, I thought I'd write this in, I'll add this in because this is just, for me, it's very interesting, and it just shows that ICD-10 doesn't quite capture everything. So the coding that we use in psychiatry doesn't quite capture everything. So ICD-11, you know, bright minds in the game put their ideas together, and we got lots of feedback from across the world and have produced an ICD-11, which is the next iteration of the ICD class of the International Classification of Diseases, which is going to be used hopefully not too distant future. But one of the things I've only taken a few, but one of the things they've mentioned is they want to broaden the category of bulimia to include subjective binge eating. They also want to broaden the category of anorexia nervosa, so it doesn't necessarily require that there's amenorrhea. Also, they want to extend the weight criterion to include any significant underweight. So actually, it won't just be 17.5. It might be even slightly, even as up to what we would consider a normal, if you like, healthy BMI. And they want to include, which I think is so key, and this is something I'm quite passionate about, the culturally relevant criteria. They want to include that in the diagnosis of anorexia, because and you know, because it is critical. We're not all the same, and people have different backgrounds, so it's very, very important that we consider that. And also, lastly, they want to introduce a severity qualifier. So we talk about, actually, this one in particular is a dangerously low weight. So we mention that when we classify it, which currently doesn't happen. And also they wanted to include a category of combined eating disorder. Basically, they want to, when someone could have at the same time a kind of a presentation of anorexia, you know, and then, you know, and it moves into bulimia nervosa sequentially. They want to be able to capture that in a diagnosis. So those are the changes for ICD-11. Some of the resources I think, if you guys have any spare time, that I would really recommend is Beat Charity, or you know, anyone who is unfortunately going through in the throes of ill health, you know, malnutrition. Beat Charity, See Charity, First Steps ED, Anorexia and Bulimia Care, and SWEDA. I think that's how you pronounce it. I've never actually said it out loud, but SWEDA, yeah. Somerset and Wessex Eating Disorders Association. These are really good resources. They have some fantastic stuff. You know, Seed Charity, massive fan of Seed Charity. They do some vital, brutally honest, and invaluable education to young people as well. And yeah, so do check those out. So these are the sources I use today. This is the boring bit, but actually the bit I'm kind of a bit obsessed with. If you're anything like me and you want to, read all these articles and research papers, feel free. I'll just put them up there. Okay. Questions. Sorry, I had to fly through that. I've never, when you put a slide I was telling Katie beforehand, I really don't like PowerPoint presentation slides. I kind of only put them together because I felt like it's just kind of status quo, right? So I had to, yeah.
Thank you so much for that. That's Chuks. That was great. I
Okay.
definitely learned a lot. So if anyone has any questions, just feel free to put them in the chat. And if not, I've just got a little question to start with.
Yeah.
Um, so I suppose, first of all, what kind of made you want to go into the field of eating disorders?
Well, okay. So interestingly, I um, growing up, I always wanted, and throughout med school, I actually wanted to do ophthalmology. I wanted to be an eye surgeon. So this kind of, so I'm still yet to go through the stages of training, if that makes sense, to get to consultant in eating disorders. But currently, I'm in eating disorders, and I've been in it for a good few years now, and I really, really enjoy it. Primarily because it's um, it's just a terrific collision of mental health, physical health, if you want to describe it that way. Some people don't like splitting the two. I just want to get across that actually the physical components of it, the bloods, the ECGs, the physical health aspect, the educational side, is so fascinating, along with the such differing presentations when you talk about the psychology aspect of things and the psychiatric side. So yeah, that's why I personally really, really like it. I just, just on a level, I try to talk to my patients in a really like relaxed, laid back way. We just trying to, the team here is just terrific in that we, just try and make, understand the patient's the difficulties of being here as an inpatient. It's very challenging. I can only imagine. I can't even imagine how challenging it must be. So we try and make it clear to them that we appreciate this. So yeah, having those kind of conversations with the patients and physical health, mental health, yeah, that's kind of why I really enjoy my job. Yeah,
Yeah, no, I totally get that. I think it really is kind of the mixture of physical health and mental health.
yeah,
And it's definitely important to kind of understand the both of them.
yeah.
So we've just got a question here. Um, I'm not sure if you know, but wondering if you could outline how to train or work in eating disorder psychiatry, as
Yeah,
you just
okay.
mentioned.
So
Yeah, I don't know.
yeah, yeah, totally. So firstly, I love, absolutely love that there's so many people involved in like the society at Liverpool there, and we need more people in the field desperately. People who are passionate and want to make a difference. And you know, if you want to get into it, to begin with, there's the application process. It has to be psychiatry as a general. So the process is broad. You apply to psychiatry, and then when you're in it, eating disorders comes under general psychiatry. So we have 3 years core training, CT1, CT2, CT3, and then there's 3 years of, if you like, specialty training, ST4, ST5, ST6. Now it's in those last 3 years that you can get to really specialize, if you like, in eating disorders. But for the first 3 years, when you apply, you have to go around and do the CAMS, general CAM, which is children and child and adolescent mental health services. You have to do the geriatric care, general psychiatry. So these are the part of the core years, the first 3 years, but it's in the latter 3 years that people can specialize in eating disorders. Yeah, it's slightly different if you do the CAMS run through, which is ST1 to ST6, but we won't get into that. It's the last 3 years of specialty training.
That's great. Thank you very much. And just another quick question. What has been the impact of COVID? I know you mentioned it's obviously put a
Yeah.
lot of pressure on the service, but
Yeah.
I suppose from your perspective, how have things sort of changed?
Yeah. Okay. So, whew, where do I start?
Yeah,
So,
big question.
okay. So, patients personally, they've been through. You talk about disrupted schedules. You know, people who like things on a certain way or have really bang right down the middle, down the line when it comes to what they eat and processing and structure. So all of that kind of went out of the window. You're talking about also sourcing items and products. It was so difficult. So much was out of stock, and it's difficult. I mean, it was hard enough for people in general, let alone someone who has specific way of doing things. Um, so yeah, and then people were it was locked down. People felt like they were quite sedentary. So some people kind of, I mean, felt like exercise was something they had to engage in more of. So then there are all sorts of ways in which kind of eating disorders has was worsened over this period. Then from our perspective, we have way more admissions, way more admissions. um, some places saying there's 20% more admissions. So we already had a lot anyway, but it's just worsened from that respect. Talk about home leave. Patients found it really difficult not getting as much home leave because in an inpatient unit, we're trying to wean the patient back into the community, trying to make the transition as seamless as possible. So they go home for 1 day, come back, go home for 2 days, come back. We see how they manage, how they fared. We reflect on it. They go again, come back. But what was happening is patients just going discharged straight into the community. Obviously, we try our best to do a maintenance meal plan here, so a meal plan that they can stay on in the community. But it's kind of like going from 0 to 100. Again, so difficult. Yeah, lots of different ways in which COVID's been really challenging. So for their sake, I'm really happy that things have eased up, and I really hope that things don't get any worse with what's going on at the moment.
Yeah, for sure. That was really interesting as well to kind of hear both sides. And then just one final question. This might be one that you might have to sort of send me an email later. So do you know of any studies or groups working on the treatment of enduring severe eating disorders, that we could look into for more information?
Interesting. Um, I've come across what I think to be a couple. I don't know whether they'll be right what you're looking for, but definitely looking at severe and enduring eating disorders. Um, Unfortunately, the research community, again, this is something I'm quite passionate about. For example, men are typically under researched. You also get underrepresented ethnic groups under researched. From my understanding, from from the articles I see, again, it's just my opinion. I have no idea whether this is the case or not, but I get the impression that those with severe and enduring eating disorders, or those who are maybe slightly older, don't get there's just the sheer extent of research in the same way. Now, there might be reasons for this, but again, this is just from I guess my personal opinion. This is kind of what I see. Maybe I'm not looking in the right places, but yeah. But I can probably send a couple over. That's for sure, for that demographic.